So yes, thank you again for being here. Just for a lot of the people in the audience who may not be, as familiar with the difference between coding, coverage, and payment, would you mind just stepping us through what those terms mean and how you think about them in your position?
First of all, I need to say thank you for including me in today's program. As usual, I'm probably going to learn more than I actually will contribute to this conversation, but um, I think I want to start so that just to manage expectations and not to have people glaze over thinking about coverage, coding, and payment, but just to back up a little bit and just say that CMS is a implementation agency that has specific authorities to implement by way of, and being that many of you are researchers, the ideal state is that CMS and other policymakers will build policy that is informed and even built on the evidence base that you all generate. And, to some of the points made earlier, um, what is really challenging about our system is that we are separated in physical and from mental health. And yet, from the clinic population that I see, I cannot think of any medical physical condition that's not somehow influenced by the mental state of the individual. So from a clinical and systems point of view, I totally understand that, the easier path may be that we divide, but I think the greater impact will be for us to together figure out how to cross this physical mental divide. Because when all is said and done, it is about achieving better outcomes for the people who we collectively serve. And HHS, the department that CMS is part of, has clearly stated that behavioral health is a priority for the department. And so we are really giving thought to how do we enable policies to be well aligned with the evidence that's created, and to be able to apply the authorities, policies, program levers, if you will, in ways that achieve those better outcomes. So thank you for indulging me and giving me the time to actually state that as far as background. So, coverage is one of the policy levers that really is very closely aligned with the evidence on many levels. I think the where it has been challenging is in a couple of ways. So number one, that the evidence that is required for coverage policy, whether national or local, has to apply to the beneficiary population that the policy would then apply to. So that means Medicare, Medicaid, marketplaces. One of the limitations has been in the evidence that older adults, people with complex health conditions, um, people with disabilities have been left out from the recruitment and inclusion in some clinical trials. Equity is an important part of this as well, so that the coverage policy can really align with and meet the needs of the individual populations who are served by the policies. So, and the reason for this may be that many research efforts focus on getting to the requirements to establish safety and efficacy, which is the FDA requirement. And yet when it comes to coverage policy, treatments and services not only have to be safe and effective, but useful in the population that is served. So it's a matter of clinical utility, not just safety and efficacy. So I want to call that out because those of you who are engaged in trials and generating the evidence, just to be aware that that is a gap in the evidence often. And Rebecca, actually, she could probably give this part of the talk because, there's really strategic thinking and work that has to happen to enable the recruitment of more complex populations. So that's one point I did want to make. The other is that, the evidence for a treatment of service is one necessary part of the translation from what you study to the care and keeping of the people who we serve. The other part of it is that treatment and services actually, whether it is a invasive thing or it is a technologic thing, has to fit into a benefit category, and this is part of the coverage requirements. So, and think about this, the benefit categories were established years ago, before much of what we see is possible was even thought of. And yet those categories are laid out in the statute, the Medicare statute. So, how we actually get to coverage of some things that are beyond the neat buckets of benefit categories can be challenging. But, it's a matter of, so how do we get close? What's the evidence and what is it? And to ask the question, what benefit category might X, Y, or Z actually fit in? So I want to say that because, software or analytic packages are not a benefit category under Medicare. Now, Medicaid has greater flexibility in terms of, what, how, and who delivers and how that can be. Much of that is left to the discretion of the state, but nonetheless, evidence is required to support the request, the case. So there are a couple of pieces here. There's, the coverage, which includes the evidence, outcomes that matter, all of which should apply to the beneficiaries who are the recipients of the Kerns services, and also benefit categories. In addition, though, there's coding, which is how similar is the new thing to something that already exists? Is this a code that is there a code that can be applied? And if there's not a code that can be applied that gets close, then that is another thing or another step that has to be taken, because it is coverage, coding, and payment. And the last part of this, payment, actually is about, so there are different vehicles that CMS can pay by way of. Many of the payments actually are prospectively established. So, inpatient hospital care based on, the composition of the population to which a condition applies, end-stage renal disease care. There are these are all prospectively paid. Hospice care is another example, home health care. So these are all payment vehicles and programs that go beyond paying for an individual thing or device. So often it will be rolled into a payment vehicle depending on what it is. I will say that, all in all, some of the comments made earlier about, how do we actually get to higher value care? It may be that new and alternative payment models, which are being tested with the purpose of establishing a different way of caring for or different way of paying for things, really still have to either elevate quality or reduce costs, and preferably both, all of which we hope will help to support the evolution towards care that improves on the health outcomes for the populations who we serve. So I'll stop there and hope I haven't had people glaze over with coding, coverage, coding, and payment. But I think, this is, these details can really matter. And if you think about it ahead of time, you can actually better understand some of the boxes that need to be checked in order to get to, a positive coverage determination. So I'll stop there. Thank you, Daniel.
No, thank you. And again, it is crucial to have, codes and, some way to fund the implementation of a tool or of a treatment modality. That's just the nature of our system. And I'm curious, with a lot of innovation coming out on around like population level down to individual level risk detection, or even trying to monitor longitudinally different patients to try to develop risk. It's not really like a treatment, but it's a way of establishing health baseline and then changes from baseline. Like, are there going to be like innovative ways of tracing, innovative types of billing coding, or it's hard to think of how that might be binned within the current framework, at least the way I've understood it.
Yeah, it's a really good question. It's about, and I think it gets closest to managing populations and payment, population-based
Right.
payment. And population-based payment has long been on the evolutionary scale of translating and evolving from volume to value. I think it is dependent on having data sources that really are reflective of what was done or what services were delivered, and also what was achieved by way of, those services. What is appealing about it, though, is that there's shared accountability, for across an entity who is providing the service. Let's pretend it's a healthcare system or it's a provider group. And there's also the importance of the attribution of individuals into that population. All of this is predicated on having data that can permit that type of analyses. So the data that CMS has and generates includes, of course, administrative claims data, and also has worked diligently actually to identify and define data elements that would translate across care settings that individual clinicians could use, but also those same data elements could inform, I think David also mentioned, quality measurement, numerators in a quality measure as applied to either publicly reporting, or even value-based payments. So we started with domains that would matter across any condition, right? And people with pain, chronic or acute pain, people with multiple conditions could actually see themselves in including mobility function, self-care, cognition. That would be universal as far as the applicability not disease specific. So hopefully that answers some of your question. Over.
No, it does. Thank you. And so I thank you for kind of stepping us through that. I think that having that long range goal in mind when you're developing an idea or bringing it through the steps of implementation into clinical practice is just essential.